Hello everyone and welcome to my channel. So we have started the preparation for obstetrics subject and we have discussed the following topics, that is the preterm labor, the premature rupture of membrane, the antenatal care, the fetal well-being, the importance of ultrasound, the RH ISO immunization, the labor, the fetal presentation, the stages of labor, the management of labor and the pathogram. Now we will discuss the analgesia during labor, abnormal labor, cephalic disproportion, malposition, malpresentation and external cephalic version. Okay, so starting from the first topic of today, we are having the pain relief or analgesia during labor. Okay. So we are having a scenario that pain relief during analgesia, what are the different methods and what are the advantages and what are the disadvantages. So first we will discuss the pain relief methods for the pain of labor, and then we will discuss advantages and disadvantages. Pain. Labor is a painful process. Pain during first stage of labor results from the uterine contractions and cervical dilatation, which is later joined by the pain from the stretching of lower genital tract and perineum during the second stage of labor. Now the types of pain are somatic, that is vagina, vulva, perineum, and it occurs in the second stage, while there are visceral pain which occur from the lower segment of the uterus and cervix. The pain fibers goes, that is T11 to L2. The pain of first stage of labor enters the spinal cord at T11 L2 through the symptomatic fibers, and the analgesia effects must focus on blocking these fibers. The pain during second stage is transmitted through the pudendal nerve to the cord at the level of S2 to S4. Okay, now the types of analgesia. We are having the non-pharmacological methods, the pharmacological methods, the inhalational analgesia, the epidural analgesia, and the spinal analgesia. The non-pharmacological methods are one-to-one care in labor from midwife or effective birth partner has been shown to reduce the need for analgesia. Relaxation and breathing exercise may help the woman to manage her pain, and homeopathy, acupuncture, and hypnosis are sometimes employed. Abdominal decompression. Relaxation is when warm water during first stage allows the woman to cope the pain. Transcutaneous electrical nerve stimulation works on principle of blocking pain fibers in posterior ganglia of the spinal cord by stimulation of small different fibers. All these methods have shown to provide some relief, especially during early part of labor. Now the pharmacological methods are opiates such as pethidine and dimorphine. Opiates are tend to be given as intramuscular injections. However, an alternative is a subcutaneous or intravenous infusion by a patient-controlled analgesia device. The side effects are nausea, that is vomiting. They should always be given with antiemetics. Then maternal drowsiness and sedation may occur. Delayed gastric emptying and short-term respiratory depression on the baby and possible interference with breastfeeding. The inhalational analgesia is nitrous oxide in the form of Intonox. An equal mixture of NO and oxygen is used in labor wards. Now the advantages are it has a quick onset, a short duration of effect, and is more effective than pethidine. The side effect or disadvantages of inhalational analgesia are that it may cause little headache and nausea. It's not suitable for prolonged use from early labor because hyperventilation may result in hypocapnia, dizziness, and ultimately tetany and fetal hypoxia. It's more suitable later on in labor or while awaiting epidural analgesia. Now, epidural analgesia, that is regional analgesia. Epidural analgesia is the most reliable means of providing effective analgesia in labor. The indications are that it is more effective than for pain relief. It is used in prolonged labor. It is used in maternal hypertensive disorders, multiple gestation, certain maternal medical conditions, and high risk of operative intervention. Contraindications are coagulation disorders, local or systemic sepsis, hypovolemia, insufficient numbers of trained staff, both anesthesia and midwife. Now, an epidural will limit the mobility and for this reason is not ideal for women on early labor. However, a woman is in severe pain even in the latent phase of labor should not be denied regional anesthesia. The complications are dural puncture, accidental total spinal anesthesia, spinal hematoma, neurological complications, drug toxicity, bladder dysfunction, backache, hypotension, and short-term respiratory depression of the baby. Now, spinal anesthesia. A spinal block is considered more effective than that obtained by an epidural and is of faster onset. The indications are C-section, trial of instrumental deliveries, manual removal of the retained placenta, repair of difficult perineal and vaginal tears. Spinals are not used for routine analgesia in labor. The method is a fine gauge atraumatic spinal needle is passed through the epidural space through the dura into the subarachnoid space, which contain the CSF. A small volume of local anesthetic is injected, after which the spinal needle is withdrawn. Now, what is the technique of epidural analgesia? First of all, clean the woman's back and local anesthetic is used to infiltrate the skin. The woman may be in extreme left lateral position or sitting upright but leaning over. Aseptic technique is used. The epidural catheter is normally inserted at L2 and L3 or L4, L5 interspace and should come to lie in the epidural space, which contains blood vessels, nerve root, feet. The catheter is aspirated to check for position, and if blood or CSF is obtained, a test dose is given to confirm the catheter position. Test dose is small volume of dilute local anesthetic. The epidural solution is usually a mixture of low concentration local anesthetics, that is 0.6 to 0.1 with an opioid such as fentanyl. Combining the opioid with the local anesthetic reduces the amount of local anesthetic required, and this reduces motor block and peripheral autonomic effects of the epidural. For example, after loading dose is given, the mother should kept in the right or left lateral position, and her blood pressure should be measured every 5 minutes for blood pressure should be managed for every 5 minutes. So we have discussed the topic epidural pain relief or analgesia during labor, and first we have discussed that what is pain. So it is the labor is painful process, and pain during the first stage of labor results from the uterine contractions and cervical dilatation. Now we have types of pain, that is somatic pain and visceral pain. Somatic pain is from vagina, vulva, perineum, and the visceral is from lower segment of uterus and cervix. Then we have the types of analgesia. These are non-pharmacological method, pharmacological method, inhalational analgesia, epidural analgesia, and spinal analgesia. Okay. Now the non-pharmacological method. We have discussed the non-pharmacological methods. Then we have discussed the pharmacological methods. Then the inhalational analgesia. Then we have discussed the epidural analgesia, the indications, the advantages, and the complications and the disadvantages. Then we discuss the spinal anesthesia, the indications, the method. Then we discuss the technique of epidural analgesia. Now we will discuss the abnormal labor along with the scenario. Okay, for abnormal labor, we are having a scenario that there is a 35-year-old G7 P6, 38 weeks pregnant with obstructed labor. She is brought to the labor room. How would you manage her? Another scenario is that there is a G6 P5 comes to labor room in obstructed labor. How you manage her? And G9 P8 comes to labor room with obstructed labor. Define obstructed labor, the causes and the complications. And G9 P7 plus 1 and presents with labor pain for last 12 hours. History of oxytocin at home, and the patient is febrile and dehydrated. Vaginal examination shows dry, hot vagina and big caput. So what is the diagnosis, the causes and the complications? Now we are having abnormal labor. That labor becomes abnormal when there is poor progress as evidenced by delay in cervical dilatation or descent of presenting part, and or the fetus shows signs of compromise. Also, if there is fetal malpresentation, a multiple gestation, a uterine scar, or if labor has been induced, labor cannot be considered normal. Now we are having the abnormal labor is obstructed labor and prolonged labor. Obstructed labor, failure of the progress of labor due to failure of cervical dilatations or descent of the presenting part in spite of good uterine contractions is obstructed labor. Then the poor progress of labor, it is defined as cervical dilatation of less than 2 cm in 4 hours, usually associated with descent second rotation of the fetal head. Then the poor progress in the first stage of labor. Progress in labor depends on 3 variables, that is 3 P's, that is power, passage and passenger. That is the efficiency of uterine contractions. Power, the passenger is the fetus with particular respect to the size, presentation and position, and the passage is the uterus, cervix and bony pelvis. Now the causes of obstructed labor are birth passage, that is contracted pelvis, dysfunctional uterine activity. Then pelvic mass, that is lower segment uterine fibroid, ovarian cyst lying in the pouch of Douglas, pelvic kidney tumor of the neighboring structures, rectum, bladder, etc. Then uterine anomaly, it is the obstruction by one horn of the uterine circulation. Then obstruction caused by the lower genital tract. These are cervical or vaginal stenosis, congenital vaginal septum, or additions from the previous tract. Then due to the fetus, that is the passenger, the fetal microsomia, malpresentation, transverse lie, bro presentation, occipito-posterior position, and mento-posterior position causes the prolonged labor or abnormal labor. Then congenital anomaly, that is hydrocephalus, hydrops fetalis, fetal ascites, abdominal tumors, and conjoined twins. The cephalopelvic disproportion is the cause of obstructed labor. Now, the poor progress in the second stage of labor is the birth of baby is expected to take place within 3 hours of the start of the active second stage, pushing the nulliparous woman, and 2 hours in parous woman. Delay is diagnosed if delivery is not imminent after 2 hours of pushing in nulliparous labor and 1 hour for parous woman. The causes of second stage delay is abnormalities of the power, the passenger, the passages. The secondary uterine dysfunction is common cause of second stage delay and may be exacerbated by epidural analgesia. Delay in the second stage can also occur because of the narrow mid-pelvis, which prevents internal rotation of the fetal head. This may result in arrest of the descent of fetal head at level of ischial spine in transverse position, a condition called deep transverse arrest. The clinical features are the history of prolonged labor, the history of prolonged rupture of membrane, and the history of syntocinon, that is oxytocin injection. The management options are evaluate her by brief history for antenatal record and medical illness. The examinations are GPE, that is exhausted, dehydrated, dry, dip, dry, acidic breathing, hyperpyrexia, causes of the membrane rupture, increased pulse, decreased BP, and purulent vaginal discharge. The abdominal examination for fetal lie is done, that is presentation, the caput, the molding, and the uterine contractions, hypercontracted uterus, and the Wendt's link formation, and the hyperdistended bladder. Per vaginal examination is done for bicep scoring, for cervical dilatation, for presenting part, caput, and molding, for placental membranes, for edematous vulva, hot and dry vagina, thick anterior lip of the cervix, and fixed presenting part, pelvic diameter, pelvic mass, and filmers for NVD. The investigation options are ultrasound for fetal lie, biparietal diameter of the head, FBC, HB, RBC, and CTG. Resuscitation is done to stabilize the patient, reassurance to relieve mental stress, the BP and pulse monitoring is done, catheterize the patient and monitor input and output record, intravenous fluids to correct the dehydration, antipyretics are given, that is paracetamol, and monitoring for the complications of shock and acute respiratory failure is done. Okay, now the delivery mode of the delivery will depend upon the cause of abnormality in the progression of the labor and the primary dysfunction labor. First of all, artificial rupture of membrane is done, which is followed by oxytocin infusion if contractures are not adequate. Then proceed to the instrumental delivery if cervical dilatation is 7 to 10 cm. C-section is done if failure to progress despite corrective measures and adequate contractions, cephalic disproportion is suspected. For secondary arrest, exclude cephalopelvic disproportion and caput and molding, then administer oxytocin only. Secondary arrest is due to the occipito-posterior position or deflexed head. C-section is indicated when all corrective measures fails. Fetal distress recommended on CTG, maternal distress, and CPD diagnosed. The complications are sepsis, PPH, fistula, paralytic ileus, asphyxia, and sepsis and death. Okay, so we have discussed the the prolonged labor. Okay, this is the prolonged labor, and the definition is when combined duration of the first and second stage of labor is greater than 18 hours in primigravida and greater in 12 hours than in multiparous. The causes of the prolonged labor are cervical stenosis, medications, anesthesia, the past ops history, the malpresentation, cephalopelvic disproportion, the family history, the ineffective contractions or ineffective maternal effort, and black woman is less prone, and fetal malpresentation and other abnormalities. The diagnosis is on knowledge of duration of gestation. Then management is induction of labor, and the complications are fetal complications and maternal complications, which are the risk of antenatal intrauterine death, fetal distress, increased incidence of the birth trauma, and shoulder dystocia. The maternal causes are anxiety, risk of prolonged labor and instrumental delivery, and the risk of C-section. So we have discussed the abnormal labor. Okay, this is the abnormal labor. First, we have discussed that what is abnormal labor. Then the abnormal labor, we have obstructed labor and prolonged labor. So first, we discuss the obstructed labor. In obstructed labor, there is poor progress of labor and the poor progress in the stages of labor. This is due to the power, the passenger, and the passage. The causes of obstructed labor. Now, in detail, the birth passage is the cause. Then obstructed caused by the lower genital urinary tract. The fetus, that is the passenger. Congenital anomaly may become the cause of the obstructed labor, cephalopelvic disproportion, and the poor progress in the second stage of labor. Okay, for second stage of labor poor progress, we have the following clinical features, and we will provide the following management options. In the clinical features, there will be history of prolonged labor, history of the prolonged rupture of membrane, and the history of oxytocin injection. Okay, now after management, examination, abdominal examination, and per vaginal examination, and then investigation and resuscitation is done, and then delivery is supported. For primary responsive labor, artificial rupture of membrane is done. For secondary arrest, the C-section is indicated when the following measures occur. This is important. It is all corrective measure fails. Fetal distress recommended on CTG, maternal distress, and CPT diagnosed. Then we discuss the prolonged labor, the definition, then what are the causes, the diagnosis, the management, the complications, the fetal and the maternal complications. So we have discussed the abnormal labor. In abnormal labor, first we discuss the obstructed labor and then the prolonged labor. Now we will be discussing the cephalic disproportion.